One unique thing about congenital heart surgery is that oftentimes we're having to go back into the chest to do an operation in the setting of someone having had a previous operation. When you do that, the main issue that we as surgeons deal with is that there's a lot of scar tissue in the chest. And so we look carefully from the pre-op phase at all the imaging to figure out if there are any structures, such as the aorta or a conduit or a coronary artery or the heart itself, that may be very close to the breastbone that we have to divide, or potentially even stuck to it. And if we perceive that that's a little bit higher risk than we'd like, oftentimes we'll go on the heart-lung machine using an incision in the groin to then be able to more safely get into the chest and tolerate better any potential injury that might necessarily have to happen just to get back in. In the meantime, we have a special set of adjuncts here, a camera called the endo-eye camera, as well as a special retractor called the rule tract. It's used routinely in adult heart surgery for coronary artery bypass operations, but we've employed it in a unique way to be able to lift the chest away from the heart, and then with a camera on the end of a very thin pole, we can look underneath the breastbone to then use special instruments to separate the heart and those great vessels away from the sternum and see everything that we're doing as we're doing it. So that ideally, by the time we bring the saw onto the field and divide the breastbone itself, we've got plenty of cushion in between the heart and the great vessels and the sternum so that the risk of injury is minimized. Our practice here has evolved to having a very low threshold to use the endo-eye and the rule tract to provide what we feel to be a safer reentry sternotomy.